Good afternoon, everyone. Thank you all for joining this collaborative session on integrating community health workers into healthcare systems. This program would not have been made possible without our partners from the National Network of Public Health Institutes and the CDC. We're very excited to bring this to you all to learn about the opportunities, the best practices, the insights on how we can integrate and authentically integrate and value our community health workers into various systems to address health disparities faced within our Latino communities and varying levels of organizations. Great. As we get started, I just want to make sure that we go over some housekeeping items. Please ensure to keep your lines on mute during this presentation to help reduce any background noise so everybody can hear the amazing content that we're going to be talking about today. We would love for you to turn on your cameras if you're in a space to do so. We understand that sometimes you're not in an environment to do so, so that's okay, but it would be great if you can. We would love to see your lovely faces. We also have a couple of MLU support staff that they can provide any tech assistance. If you have any issues, please raise your hand so that our support staff can address any tech assistance that you may require. And this session will also be recorded and will be shared publicly post this session. We also want to make sure that you all hold your questions until the very end. We have a very packed agenda for today, so questions will be taken at the end of this session. All right, so let's get us started. So here's just a quick agenda of what we'll be covering today. We're going to be going over an introduction of community health workers and what you'll be learning today. We'll also be going through and listening to an amazing panel that we have set for you today from La Clínica del Pueblo, Latino Health Initiative, and Maryland Physicians Care. They will be sharing their insights from the field. And then we will have our Q&A session. In the meantime, we would love to know who's here, who's in the room with us. So if you can please put your name, your organization, and your role in the chat so we can know who's here. All right, so let's get started. So I want to make sure that you all know who we are, who Maryland Latinos Unidos is. Maryland Latinos Unidos was established in 2020, right at the midst of the pandemic, to unify statewide efforts to support Latino and immigrant populations. We are a statewide network of Latino and non-Latino leaders to form a collective voice. Our motto is Juntos Podemos Más, together we can do more. Our mission exists to call attention to the disparities and inequities faced by Latino and immigrant communities, to find solutions and to address these problems with coordinated action. And our vision is a world where your zip code does not determine your lifespan. We are a nonprofit, and we really are excited to ensure that we are working towards achieving health equity for our Latino and immigrant communities. Here are our lovely MLU staff. My name is Kelly Umaña. I am a certified community health worker. I am also a doctoral candidate at the George Washington University Milken Institute of Public Health. We also have Dr. Gabriela Lemos, who are executive director. We have Walter Sava, who is our senior program manager of health equity programs. And we have Kimi Ortiz-Tai, who is our community health organizer. And all of us are here to help support you as you are in this journey with us to integrate CHWs into health systems. All right, so our goals and objectives today. So we hope that, we really hope that you are here to learn more about community health workers. They are such an integral part of our overall public health system. And really this conversation today, or this collaborative session, is to help organizations, local health departments, nonprofits, community partners, everyone from every corner of this earth to learn and understand the impact community health workers have on public health and what they do to really bridge the gaps between disparities and inequities that our communities are facing, and seeing the diverse ways that they can they have experiences in various systems, which you'll be hearing on later on today. But we also want to ensure that you have a foundational understanding of who community health workers are, what their skills are, and how they bridge health gaps in our communities. And then again, we'll be hearing from our presenters later in this session. But before we get started, I want to make sure that we launch a poll. We want to hear from you. So you have a poll that just popped up on your screen if you all can participate in this poll, so we can learn more about where you are and your understanding and your familiarity with community health workers. So the first question is, on a scale from 1 to 5, how familiar are you with who community health workers are and their role in the field, with 1 being the least familiar and a 5 being the most familiar? How many community health workers do you have in your organization? How long has your organization had community health workers? And did the pandemic introduce you to the impact of community health workers? We know during the COVID-19 pandemic, a lot of organizations learned about who they are and what they do. And especially with all the funding that came through. So we just want to get a pretty good understanding of where you all are in your understanding of community health workers. So I'll just give you all another minute to complete this poll. We have about 54 participation right now. If folks are unable to see the poll or unable to enter your responses in the chat, please let us know. But we'll give a few more minutes. And if you haven't done so, and if you've just joined us, please do put your name, your organization, and your role in the chat so we can know who's in the room with us today. All right. All right. Great. Just another minute and then we'll end the poll. All right. So we have really great, as you can see in the poll, we have a really great balance between who familiarity with community health workers, how many you have in your organization. And yeah, many folks learned about community health workers and their impact during the pandemic. Very interesting. All right, so I think we can go ahead and get started in who community health workers are. All right, let me get this out of the way. Great. All right, so who are community health workers? Based on the definition of the CDC, a community health worker is a frontline public health worker who has built a really unique and close relationship and built trust with the communities that they are serving. They are really the liaison between health and social services and facilitate access to services to improve the quality and cultural competence of service delivery. They can wear so many hats, as you can see on the pictures here on the side. They can be in communities, they can be in healthcare settings, they can be providing education classes. But really the central part of community health workers is building that relationship and that trust with the community. Oftentimes, they don't have an opportunity to build certain relationships or trust within, outside of their communities or with certain settings that they have to be in. So that community health worker really connects all of those dots and ensures that their communities that they're serving are empowered, have autonomy, have all the support they need in a way that works for them. So community health workers are really, really that interconnection and that central part of cultural affirming care and culturally tailored care, no matter what the system is. So they're able to make that unique relationship and that unique trust with their communities. But community health workers, who are they? Like, what are their names? What do they do? Oftentimes, community health workers can have so many names. They can look so differently in so many different organizations. They can go by community health advisor. Especially in the Latino programs, they're called promotores de salud, health advocates, they're outreach workers, patient and health navigators. They can be peer counselors. So they can have various names within the organizations that they may be serving or they may be working in. So they're not just bound to the name as a community health worker. And as I mentioned, they work in various locations. They can work in locations such as hospitals and nonprofits. Here at Maryland Latinos Unidos, we have our community health organizers that serve their specific counties. They become this trusted liaison between the communities in their respective counties and the programs and work that we at MLU do. They work at health departments, at faith-based organizations. They can help support food distributions, or they can help tie social services between the faith-based organizations and the communities that the FBOs are serving. They can work in health insurance programs, and they can also work in community health centers. But this is a non-exhaustive list. There are so many other places that they can work in. But this is a big of some of the big ones that they may be working in. And something about community health workers is that they're growing. It's such a growing field. According to the US Bureau of Labor Statistic, they have a 14% growth between 2022 and 2032. And this is a much higher rate than many other occupations, especially in the healthcare field. We know that there's a need for nurses, providers, but there's also a huge growth in the community health worker field. So we know that there are many of them out there looking for job opportunities, and there are many organizations looking for them to employ them into their organizations. So what is a community health worker? How do they work? How do you hire one? What do you look for? What are some things that they have to serve the community? So based off the Community Health Worker Impact Coalition, they have found a couple of characteristics, but again, this is a non-exhaustive list. I just want to preface this by saying that all community health workers have different educational backgrounds, cultural backgrounds, and skills. It's up to the organization to see what their needs are, but many community health workers have very similar characteristics, that they are deeply connected and rooted in their community. They are a natural helper. When I was talking to a community health worker the other day, she was telling me how one of the main things that she does is when she hears a problem, she needs to act on it. There's something that inside of them that tells them that they need to help. They are open-minded. They work with so many community members. Oftentimes, it's not just the Latino population. They may be working in such a diverse community that they are very open-minded and willing to work with anyone. Friendly, outgoing. They knock on doors. They go and talk to communities about certain events that are happening. They create their own networks and WhatsApp groups and Facebook groups to really share the voice and share information across the communities that they're serving in their networks. They're patient. They have to work with the community, and they know that this requires so much patience and learning. They're honest, respectful, and they're persistent, creative, and empathetic and compassionate. So these are some of the core characteristics that they may have. But again, as I mentioned, they all have different backgrounds. They all have different skills. It's about leveraging each and every single one of their abilities to help support them in their professional career and journey as a community health worker. And so what are some of the services that they offer? So according to the Rural Health Information Hub, these are some general buckets of some of the work that they're doing. Advocacy, they advocate for their community members. In the example of the hospital, they oftentimes have health advocates within the hospital system to ensure that the patients and the patients that the hospital is serving, their patients feel that they are empowered, feel that they have all of the information that they have to make decisions regarding their health. And if there's something that they don't understand or something that it kind of seems off, they have that health advocate to support them. But also not only just a one-on-one advocacy, but they also do group advocacy. They oftentimes are deeply rooted in communities and oftentimes see issues that many other organizations, politicians, or decision makers are not seeing. So a lot of times community health workers may be seeing common themes in different communities about certain issues that these communities are facing. They can unify their voices and really go up and really ensure that these organizations, decision makers, and politicians are truly seeing the eyes of what our communities are experiencing on the ground. They do a lot of outreach and enrollment. Oftentimes, community health workers are out in the field. They are in grocery stores. They are on laundromats. They are in health fairs. They are going into every space, into bars, providing flyers around HIV. You see them in every single crevice of this world, and they are ensuring that no person is left untouched. So they're oftentimes doing outreach and ensuring that the communities are receiving information that is out, like SNAP benefits, like Medicaid, how to enroll in Medicaid, into programs that oftentimes organizations are putting out, but may not be reaching communities. So community health workers can really help bridge a lot of that, and especially enrollment. We know enrollment, even myself, somebody that knows the language, that studied here and et cetera, when it comes down to services, there's so much paperwork, there's so much documentation, there's so many different things that we have to navigate and understand, that community health workers can really help ensure that the communities and patients know what services that they need, how to enroll into them, and what documentation they need to provide. And then where navigation is, they navigate everything. They have to. They navigate the complicated healthcare system. They navigate the different programs that are in the communities or not in the communities that they need in the communities. They provide education workshops, health services. They can go into communities and actually do blood pressure checks. There have been times where they can actually help support community members or during health fairs or during certain outside settings and doing COVID-19 testing. During the time of COVID-19, when the at-home kits came out, it was so challenging to use those COVID-19 kits. I felt like I had to become my own doctor at home. And so what ended up happening is many community health workers actually help support community members on how to use them. So they really help bridge that health literacy gap. And I put research here that wasn't included in the Rural Health Information Hub, but they also help support research. We know that research is challenging and there's very low enrollment rates of Latinos and people of color into clinical studies. I know during the COVID-19 pandemic, Casa de Maryland had the promotores reaching out to community members to participate in clinical trials for COVID-19. And it's social emotional support. They become this trusted member of the community and they become this person that anybody can lean on. And so they are really ensuring that they are compassionate, they're showing empathy and compassion with the community members that they're serving. A lot of promotores and community health workers also provide mental health support. They can get certified in mental health and they can also ensure that mental health gaps are being reached. And so how do they bridge gaps in the Latino community? We need to talk about social drivers of health. And what are social drivers of health? Education, economic stability, health, social and community context, and neighborhood and built environment. Community health workers really touch many of these. They really work towards ensuring that our communities are being touched in a holistic way. Oftentimes certain programs or certain services only touch on education or only touch on health. Just to give you some context, our overall bodies, only 20% of it entails healthcare. So community health workers can really look at a person holistically to ensure that they are being provided services and being provided the support in all of these aspects to address social drivers of health. So how do they do that? So some of the things that community health workers do is they educate community about services. They ensure that communities have access to resources. They do classes and workshops such as diabetes workshops. They can do mental health workshops. They can provide support groups in their respective languages and in a way that the community can understand. They also work in schools. Sometimes community health workers can partner with schools to reduce education gaps. In terms of economic stability, they are improving the representation in the healthcare workforce, especially in workforce in general. They also reduce the cost of care for Latino community because they focus primarily on prevention. A lot of times our healthcare systems are very reactive and focusing on chronic conditions, but they really work towards focusing on prevention. According to American Hospital Association, community health worker interventions save $2,245 per patient. In healthcare, they navigate health systems in a manner that is understandable to the community. This system is completely complicated, and I'll say that myself because I've been through it. I've seen communities go through it. As a certified community health worker, I've seen it firsthand. And they are really able to ensure that they can navigate ways and understand how they're going through these systems to help support them and ensure that they're achieving optimal health through receiving services and benefits that they need. They also helps Latino communities and patients feel empowered, feel autonomy over their health. Sometimes our community members don't have the opportunity to speak up, and community health workers can help empower them to feel that they can make those decisions for themselves, can ensure that they're making the decisions and having a conversation with providers, with the service providers that they are going to. And they help prevent and manage chronic conditions such as HIV and diabetes, which we'll hear more about some of the work later on in this presentation. And in terms of environmental health in the social and community context, they address environmental factors in their communities. They are ambassadors for climate health. They bring the services into communities that oftentimes it may not be there. We know that there's so many programs and services that exist, but unfortunately, they might not be going into communities that really do need it. So they really ensure that services are going into communities and that the communities are being able to access it. There have been some programs that community health workers establish community gardens or programs or interventions within their specific communities. And lastly, bringing together our community members together. As I mentioned earlier, they really unite communities in advocating for particular issues that they're seeing in their community. They address physical health. Sometimes community health workers put together Zumba classes or art classes or anything that best serves the respective communities that they're serving. And they also promote social justice. They ensure that the communities are not left behind. They ensure that the communities that they are working with, that their voices are heard. So I wanted to ensure that all of us have a foundational understanding of who community health workers are, what services they provide, how they build really bridge the gaps between the Latino community and the systems that they're and healthcare systems in general. But I don't want to be the only one talking today because there are so many amazing people doing incredible work. So I think this is going to be I'm super excited for this part. I'm sure many of you are as well. But we're going to be hearing from folks from the field on best practices, opportunities, and insights. I'm very excited to see such a diverse panel here from organizations where they're working in that provide community health worker programs and have longstanding community health worker programs. So I'm going to first start off with some introductions of our presenters. And then we're going to move directly into the presentations from our panel today. So first we have Manuel Diaz Ramirez from La Clínica del Pueblo. Since 2018, Manuel is the Director of Community Health Action at La Clínica del Pueblo in the Washington, D.C. metropolitan area, overseeing La Clínica's gender and health promotion and prevention programs, and the health promoters and health literacy strategies. From June 2007, when he joined La Clínica del Pueblo, to November 2018, Manuel served as the LGBTQ health program manager at managing HIV prevention programs and safe spaces for the Latinx LGBTQ recent immigrant communities. Before immigrating to the United States in 2005, and for about 10 years, Manuel worked for a community health center in Lima, Peru, as a project manager implementing prevention and sexual health programs targeting men and youth, including training initiatives for health promoters. Manuel graduated and is a licensed social psychologist and later studied public health and gender. He has 30 years of professional experience. Manuel received the 2018 and 2023 Unidos Us LGBTQ Champion Award by Unidos Us in recognition to La Clínica's exceptional leadership and commitment to the LGBTQ community through its programs and services. He was also awarded with the 2015 Community Leader Award by the Latino GLBT History Project during the 10th Annual Hispanic LGBTQ Heritage Awards in September 2015 in Washington, D.C. Manuel currently lives in Fairfax, Virginia, with his 25-year-old daughter. Next, we have Giannina Haskun. Giannina serves as a coordinator of the Vías de la Salud Community Health Worker Certification Training Program with the Latino Health Initiative, Department of Health and Human Services of Montgomery County, Maryland. She has been working with the Latino Health Initiative since 2006 where she has been responsible for designing, implementing, and evaluating health promotion programs, in addition to developing curricula, educational material, and implementing trainings to health promoters and community partners. Gina holds a bachelor's degree in psychology from the Central American University San Salvador and a master's degree in human systems intervention from Concordia University in Montreal. She has over 30 years of experience working in community health programs, including the mental health field, both in her native country, El Salvador, and the Washington, D.C. metropolitan area. In El Salvador, Giannina worked in post-war communities, designing and implementing psychosocial interventions for children, youth, and families, utilizing popular education methodologies. She co-authored the book, Weaving Our Identities, Psychosocial Intervention with Families of Disappeared Children Due to the War. Currently, her work focuses on public health, providing capacity building to community health workers as a way to address health disparities, facilitate access to culturally and linguistically competent health services, and engage communities in their well-being. And then lastly, we have Dr. Lorena de Leon from Maryland Physician Care. Dr. Leon has over 25 years of clinical and operational experience, including program development, strategic planning, digital health and technology, and affordability/cost savings. She is currently the Senior Director of Population Health and Social Determinants of Health for Maryland Physician Care, the third largest Medicaid managed care organization in the state of Maryland. She has served in leadership roles for organizations including United Healthcare, Optum, Johns Hopkins, and the Office of Healthcare Quality. Lorena holds a bachelor's degree in business management and an MBA in healthcare management and a doctorate in public administration from the University of Baltimore. She also holds a certificate in value-based care from the University of Houston and is a green belt in Six Sigma and Lean certified. Wow. I mean, just wow. What an amazing panel. I'm super excited to just hear from all of them about their incredible work. So Manuel, do you want to kick us off and share your screen?
Absolutely, Kelly. Good morning, everyone. Those in the East Coast, and good afternoon to those in the East Coast, and good morning to those joining from the West Coast. And thank you, Kelly, and your colleagues for the invitation. It's an honor and a pleasure to us to be able to share along with my fellow panelists about our models of involving community health workers. I'm going to start sharing my screen, and please let me know if you're seeing my presentation mode screen.
Yeah, we can see it.
Perfect. Okay. So as I said, I'm going to be, for us, for La Clínica del Pueblo, involving community health workers is the way we have responded during the last 40 years to the health disparities in the DC metropolitan areas, Latinx immigrant communities. And we see ourselves as La Clínica del Pueblo as a public health response. So La Clínica del Pueblo is, first of all, a community health center, a community-based organization who happens to be also a federally qualified health center and a patient-centered medical home. Our story began back then in 1983 when Salvadorian immigrants and United States health advocates founded La Clínica del Pueblo in response to the emergent health needs of displaced migrants due to civil war and state-sponsored violence and repression in El Salvador primarily, and to lesser extent from Guatemala and Honduras at that time. For many of those immigrants, accessing healthcare services in the United States was nearly impossible due to the cultural, linguistic, and economic barriers that they faced. Additionally, since these conflicts happened during the Cold War, asylum and refugee status were not afforded to them as their governments were under the US influence, meaning immigrants were not legitimate refugees, unlike political refugees from countries like Cuba and other Soviet republics during the same period of time. Who we serve as La Clínica del Pueblo? We serve as our mission states the most in need. In general, I can summarize it as we serve roughly 4,500 patients per year. 91% of them are self-denominated as Latinx. 80% of them are recent immigrants, predominantly from Central America. 35% of them are insured. 83% of them feel more comfortable communicating in a language other than English. 84% have an income at or below 200% of the federal poverty line. And the majority of our patient population lives in DC, 44% in Maryland, and only 2% from Virginia, which reflects our locations. Since 1983, La Clínica del Pueblo has grown from an all-volunteer free clinic to a multi-site organization working in DC and Maryland. We continue to adapt to the growing and changing needs of the Latinx communities, with a special focus on expanding healthcare access in the Prince George's County in Maryland. We have 2 clinical sites, as you can see, one school-based mental health program and one community health and action site in the DC that houses, as we call it, La Casa, our health promotion programs, prevention programs, health equity department, and 2 of our safe spaces. The Empoderate Center safe space for the Latinx LGBTQ plus community, and our Entre Amigas safe space for the Latinx women survivors of gender-based violence. We like to see ourselves as a community of care, implementing a model from a programs and services integration approach. We are driven by a collective of more than 130 employees, 30 peer health promoters, and more than 50 volunteers, many of them first-generation Latino immigrants. We provide bilingual primary care service, mental health services, substance use programs, and we offer a community-level health education programs out in the community, focused on topics such as chronic diseases prevention, access to treatment, wellness initiatives, including healthy eating, physical activities, mindfulness. We include respiratory disease prevention and vaccination efforts, HIV and STI prevention. We promote LGBTQ health, address gender-based violence prevention, including men involvement initiatives such as co-parenting and gender transformative workshops. Also in women's sexual reproductive health and health literacy initiatives. Patients can see a medical or mental health provider, a caseworker, and a health educator in a single trip to one of our primary care centers. Patients also have access to navigation for social support services, including legal, housing, employment, insurance enrollment, and other essential support services. So what's La Clínica's model for integrating community health workers? La Clínica del Pueblo believes that community health workers are a public health workforce who has an understanding and trust within the community they serve. This relationship of trust allows community health workers to serve as a link between social healthcare services and the communities they belong. Our model responds to historical mistrusts of in our home countries regarding healthcare systems. Community health workers have helped to build a fundamental linguistic and cultural bridge between institutional medical care and traditions of care from Central American countries. Out of all La Clínica del Pueblo's staff members, 60% of our staff members were once a community health worker, volunteers or community members who share experiences of immigration and Latino culture with our clients. So in order to design and develop our model of involving community health workers, we rely on some, we include some theoretical approach. These theories provide an approach to define how peer health supporter model works to increase knowledge and foster healthy behaviors among communities. Cognitive functions originate in social interactions and must then be explained as products of those interactions. Language and culture are the common ground through which individuals experience, communicate, and understand the world around them. Therefore, the tradition of knowledge regarding self-care and community engagement is more efficiently understood if learned through modeling a peer who shares the same language, culture, and social context. In short, we learn that Popular education draws out and validates what participants already know and do, connects their personal experience to larger social realities, and then supports participants to work collectively to transform their conditions. La Clínica's community health workers are trained to use popular education techniques to transmit health education messages that are accessible to members of the community with low levels of formal education, low English proficiency, or limited access to health services. Similarly, community health workers are trained to engage in active listening with participants in the interventions and to tailor their health promotion messages to the realities of the participants' daily lives, rather than providing prescriptive advice. There is a common process that describes the popular education philosophy, although the products of each step of the process are unpredictable. A popular education experience always begins with the experience and struggles of ordinary people. Those experiences are then generalized in order to learn more about the problems that exist within society. In this model, in the model we implement at La Clínica, no one is the all-knowing teacher. Instead, there is a facilitator who guides the conversation to ensure the dialogue and help participants build on what they have learned. In summary, community health workers are crucial to engage with the community and serve as a bridge with the communities we serve. What is our scope of practice for our community health workers model? Basically, four core strategies, core elements are part of our scope of practice. Community health workers are involved in access, education, advocacy, and service delivery. Under access, they can connect consumers to the health system and or medical home. They can assist with enrollment in insurance and social programs. They can support scheduling and keeping appointments and monitoring appointments, and they can coordinate referrals. Under education, community care workers can support health promotion and disease prevention initiatives, as well as chronic disease management. They can also provide information about existing program resources and services internally and in our community. Under advocacy, community care workers can give voice to the community regarding patient needs and preferences. They can build community capacity to promote wellness, prevention, and chronic disease management. And community workers can participate in documentation and research to demonstrate the effectiveness of promotores de salud programs. Under services delivery, community health workers can provide routine screening and testing and can provide informal counseling on social support, for example, organizing stress management group interventions. La Clínica del Pueblo, in 40 years, has relied on community health workers to address a variety of health issues affecting the Latinx immigrant communities and adding unique insights to the care systems, to care teams providing planning process and institutional direction. For example, with our patients and clients, community health workers provide assistance with chronic disease management, service navigation, as well as promote healthy lifestyles for disease prevention. For out of care or underserved populations, community health workers can perform outreach activities, reducing barriers to access, provide information regarding programs, resources, and linkage to care services in a health literacy level. Under clinical academic institutions, community health workers are the community voice at the decision-making table to allow for programs and services to be tailored to community needs, as well as take part in community needs assessments and clinical trials. So our community health workers development and training includes six competencies, core competencies that we consider for the implementation of our training program. So they develop capacity under collective learning for community mobilization, in group facilitation, also about ethics and institutional policies and procedures, regarding documentation and reporting and continuous education on different topics related to the programs and services we implement at La Clínica del Pueblo. So for collective learning, based on the idea of mutual beneficial relationships rather than one person educating or aiding another in attempt to minimize the power imbalances in client health professional relationships. They reflect on the importance of learning collectively. They also learn about how efforts to improve the health and education levels are aimed to enhance the overall standard of living in the community, and the importance of their role to move in the community towards the change they are promoting to. Under group facilitation, they understand that facilitation enables and empowers people to carry out a task and perform an action. The facilitator does not perform the task, but uses certain skills in a process which allows the individual of the group reach their decision and regarding their goals to learn. Regarding our ethical institutional policies and procedures, they learn, they understand the purpose of legal and ethical dimensions of the community health worker role. And also regarding documentation, we explore with them the importance of why we collect data, why it is important for our programs and services to manage data, to manage information, and the emphasis of appropriate, accurate, and clear documentation of every intervention and services we implement in the community. And as we implement continuous education, format education increases the abilities of promoters to use what they know to enable communities of individuals to increase control of their own health. So our model's logic model, all these core competencies addresses the scope of work that we developed, that we designed for our community health workers program under education, access, advocacy, service delivery, and knowledge production, aiming to increase the levels of empowerment and the capacity to take action on their own health and the community's health at the individual, organizational, community levels, aiming at the end as a long-term impact to increase health equity among Latinx communities, immigrant communities, the ones we serve. So there are a few actions that we have been able to implement to develop and to retain this workforce in our organization. So we have a very complex structure for community health workers roles. Some of them are volunteer based, some of them are contractual based, and another large group are full-time employees of La Clínica del Pueblo. But all of them are community health workers at core. Staff time allocated to train, supervise, and mentor community health workers is being considered intentionally in our annual planning and as well as in our budgeting process. We also implement continuing engagement and enrollment process during the whole year for those community members motivated, interested in being part of this cohort, of the annual cohort of community health workers. We implement an annual comprehensive formal training program offered in Spanish from February to November of each year, addressing those core competencies and core elements of our training program. Also, we have under different programs, different consumer advisory boards initiatives that allows their involvement into providing input and feedback to the implementation of our programs and services. We have developed a comprehensive supervision mentoring system that managers and staff members in community care workers roles provide mentoring and supervision to the newest cohorts of community care workers to ensure they are developing the necessary skills to do health promotion in our communities. For those that are contractual based, we have developed a format of business associate agreement to be able to receive and a stipend for the work they do for our communities at a $70 per hour stipend rate. And when available, when opportunities arise to become full-time employees, they can apply to those positions. They many times end up being hired as a full-time employees. As a summary of some numbers, because we love numbers. In general, we can say that our annual training program consists between 30 and 47 community members participated in our annual training program. Usually 39 of them or 83% of them complete the 16 hours of general training that is scheduled every February of each year, an additional 36 hours of continuing education training. Usually each of them, they participate in at least 9 activities, events that they support at least, also at an average. And also their role contribute to the impact of our community-based programming in the DC metropolitan area. More or less, we have, they contribute to the 60,000 touch points that we reach every year in the communities. They support 441 community outreach events per year, 31,000 street-based outreach encounters. They support more than 4,000 clients linked to screening services, a variety of screening services that we provide in-house or with community partners. They support our successful linkage to care rate of 100%. All of the clients that end up in the hands of our community care workers team, 100% of them, they successfully are linked to the services that they are needed. And then for other essential support services, also 92% of them, they support also this rate, and they contribute serving more than 1,000 clients in educational sessions facilitated by community care workers. And a few recommendations. We thought about what is the importance of how we can ensure sustainability of community health programs involvement. So in our experience, it's important when health departments give credit to community-based organizations that are implementing involving community health works in their scope of work, in the proposals they are submitting for funding. Also, it's important that if health departments can foster collaborative dialogue between CBOs and community health centers or federal qualified health centers to develop strategies to incorporate community health workers into their initiatives. Also, we believe that health departments have a crucial role in promoting encounters among community health workers to share experiences based on the organizations they are serving. Also, health departments can support training opportunities to develop community health workers' skills and knowledge. And of course, health departments across the country, they can support the dissemination of data showing the effectiveness and impact of community health workers' involvement. So what can we conclude? And I hope I can address this in the last 3 minutes I have, or less. We believe that our community health worker model asserts the desired and modeling behaviors are best achieved by replicating numbers of the same groups, understand that migration exacerbates structural vulnerabilities based on gender, class, race, sexual orientation, and ethnicity. And it is important to invest, train, and incorporate community health workers to act as a bridge between individuals and the community's realities and the healthcare services. And as an example, please allow me to share one way of how community workers are involved, community health workers are involved in La Clínica del Pueblo. I hope you enjoy it. I apologize. I was told that you couldn't hear the voices in the video, only the music. For some reason, it didn't share the whole sound. That's weird. But that's an example of the materials that we use involving community health workers. And I hope you enjoyed it. Thank you, Kelly.
Thank you so much, Manuel. Our next presenter is Giannina Hasbun from Latino Health Initiative.
Muted, I'm sorry. Thank you, Kelly. Thank you, Maryland Latinos Unidos, for the invitation, and thank you all for being so interested in advancing community health workers. My name is Giannina Hasbun, and I work for the Latino Health Initiative. Just get the screen going. There it is. So I work for the Latino Health Initiative of the Department of Health and Human Services of Montgomery County. So we are one of 3 minority initiatives. We have 2 sisters initiatives, the Asian American Health Initiative and the African American Health Program. We are under the Office of Community Affairs, and this office leads the development of equitable and inclusive health services in response to racial and ethnical disinvested communities. So from that perspective, the Latino Health Initiative has been addressing the health, language, economic, and professional disparities impacting the Latino community. Our mission basically is to improve the quality of life of Latinos in Montgomery County, and how we do that is by contributing to the development and implementation of an integrated, coordinated, and culturally and linguistically competent health wellness system, of course, that supports and values Latino families and communities. So as I mentioned, we've been addressing some health disparities. I just wanted to share some data. As Manuel mentioned, data is important to reflect the impact of our work, but also to reflect the disparities in this case. You can see it here for yourself, but let's just take in terms of education, adults that are 25 or older with less than a high school diploma for the Latino community is 31.6%, versus non-Hispanic white, which is a 2.2%. So the data speaks for itself. In terms, on the other hand, in terms of bachelor's degree or an advanced degree in the Latino community, we have 23.4% versus a 72.9%. In sake of time, I'm not going to go all over them. I just wanted to highlight this one, for example, adults in the 19 to 64 years without insurance for the Latino community, that's 33.6. That means 1 in 3 Latinos do not have a health insurance versus 2.8%. So this is a reflection of the disparities that still exist in Montgomery County. This data is specific for Montgomery County. So Kelly already read this definition of community health workers. I just wanted to highlight the importance of they're trusted members of the community, or they have a very close understanding of the community they serve. So they serve as liaisons. One of our community health workers put it so beautiful. She says, we are the bridge, the bridge between the health services and the community. So they facilitate access, and they do that through a range of things: outreach, education, providing information, providing social support, and advocating. Kelly also mentioned they go by many titles, and in our case, in the Latino Health Initiative, we've always referred to them as promotoras, más que todo promotoras. I understand, and I believe some of them are here in the session today. So thank you so much for all the amazing work you do and the tireless commitment that you have shown throughout the years. But there are many other titles depending on where they work or the roles they take on. For example, patient navigator or health educator, family advocate, just to mention a few of them. So now I'd like to talk a little bit about how we have integrated community health workers in the work we do. And we have 4 areas of implementation. One of them is the training itself, training health promoters, the promotion of healthy behaviors, and facilitating access to care has been a big one, and advocacy as well. So I'll talk about each one of these areas of implementation. But I just wanted to talk a little bit about our Vías de la Salud Health Promoters Program, which has been around for over 25 years now in Montgomery County. Actually, the Vías de la Salud Health Promoters Program was developed even before the Latino Health Initiative. So it's older than the Latino Health Initiative. And the goal is to improve the health and well-being of the Latino community by training and empowering health promoters to foster healthy behaviors, facilitate access to health services, and advocate for health policies benefiting the community. And this is where we get our 4 areas of implementation. And of course, the mission is to engage the community itself in improving their health and well-being. So our model is a grassroots model, meaning that health promoters belong to the same community they serve. They share the same demographic characteristics. And many times they also face the same challenges. For example, access to health insurance. As we saw in the data, there's a big gap there. So sometimes they face these same challenges themselves. They are trusted community agents, and they have a strong bond with the community they serve. So they're breaking cultural and linguistical barriers by connecting, understanding, respecting communities' cultural values, beliefs, practices, and needs. And this is what exactly makes them trusted community agents in their communities. So I'll talk a little bit about training. at LHI, the Latino Health Initiative, LHI, a lot of what we do focuses on the training piece. So we design and implement trainings at least 60 hours per year. This is for the promotoras that are active in the program. So we focus on topics such as all preventive topics, such as the importance of healthy eating, the importance of physical activity, access to healthcare, understanding what are the eligibility requirements for the different programs, understanding the changes when there are some changes, and a lot of the training also focuses on developing leadership and advocacy. As part of the training, we also monitor activities on the field so that we are able to provide feedback right there and then as a way of quality assurance. And we have a mentoring, shadowing model in which when we have a new group of promotoras that come into the program, they're usually, aside from the formal training that they go through, they're always paired with a health promoter, with an experienced health promoter. So that's in summary what the training entails. And then the promotion of healthy behavior. As we saw in the data, Latinos disproportionately suffer from higher rates of illnesses such as heart disease and diabetes. However, our program does not focus on disease management. Our program focuses on prevention. So topics that have been topics of focus in our program has been physical activity. So they conduct what we call caminatas, and caminatas is a 6-session program, walking groups, and in hopes that at the end of the 6 sessions, participants will be motivated to continue walking in their groups or in their own or with their families, but a way of integrating physical activity. Healthy eating, we have a curriculum that the health promoters are familiar with. It's a 4-session workshop in which they teach basic but very important healthy eating information, such as the My Plate guideline, how to read labels, identifying hidden risk in foods, like how much sugar in the beverage, for example, or how much salt in certain foods, and how to buy, how to get healthy food on a budget, for example, are some of the topics. And the other topic is tobacco use prevention, but that has been, we do a lot less of that right now. We had a smoking cessation program, so they were out in the community raising awareness in terms of the effects of tobacco and inviting people to participate in the program. Also, the health promoters have participated in countywide efforts whenever needed. For example, they have participated in emergency preparedness campaigns, in pedestrian safety campaigns. When the SICA was around, they did that. And of course, most recently, COVID, but I'll talk about COVID in a minute. Facilitating access to healthcare. As we saw in the data, this is a big need in the community. So they inform residents about all the different resources there in the county, community clinics, health insurances, eligibility requirements. And they do this in a wide range of places. They participate in health fairs, in their own churches, in their children's schools, in libraries, among their neighbors, their friends. As I said, they're very trusted members in the community. So they're really great at sharing all this information. They provide referrals and assist navigating the health system. Sometimes they help fill out applications. Sometimes they actually have to go with somebody at to the health centers, advocate and build capacity as well, so people will advocate as well for themselves. Most recently, they've been using their own social media to share resources about the different programs or resources available through their own networks. And advocacy has been also a strong component for the promotoras. They bring attention to service gaps. They know the needs of the community really well. They receive all this from the community, so they bring attention to these needs and to the gaps and to the service improvements that needs to happen in the services. And they will go to the county council to advocate, or they will go to the community forums that are held by the county executive, or they will bring this up to us, like the staff at LHI. And they also are part of the Latino Steering Committee. So the LHI also have like another branch, let's say, which is the Latino Health Steering Committee. And there's always 3 health promoters that represent the group and represent the community, again, bringing attention to the needs and the service gaps. So that's a place where they also voice these needs. So that's what we've been doing in terms of the health promoters, but then came the pandemic. So when COVID came by, we basically had to stop what we were doing and focus our efforts on COVID-19. Latinos were getting sick at disproportionately rates. Also, we were the ones that were less getting vaccinated. So with this information, the county executive and council members, Albornoz and Navarro, and 7 local organizations, they all partnered together, creating, maybe you have heard the name Por Nuestra Salud y Bienestar initiative in response to this. So I just want to quickly share this graphic here, in which when the vaccines came out early on, you could see there's a big gap in terms of Latinos getting vaccinated versus towards 6 months into 8 months into, the gap starts getting narrower and narrower, to a point in which the gap basically closes off. And that's in part due to the work and the efforts that community health workers put into this. So just as reference, the Salud y Bienestar program is a very comprehensive program. So it had, the testing component, the vaccination, clinical follow-ups. There's a communication piece to it. Maybe you have seen Abuelina in some ads on TV or radio. Abuelina was developed, it's a grandmother figure that provides information about resources and about the vaccine, the importance of getting vaccinated. There's a case management component. Of course, there's an information line. But I want to focus on the community outreach, because that's the work that the community health workers did. And we strongly believe that the gap was able to get a lot more narrower because of the efforts that the community health workers did in the community. I'm not sure how I'm doing with time, Kelly. So this all happened very quickly, and the program was developed very quickly, and a cadre of approximately 60 health promoters were recruited. Many of our health promoters that were working with LHI joined this initiative, and other health promoters from other organizations as well. But there were every day for 7 days a week, at least 20 health promoters out in the community, reaching the community where the community was, promoting the testing and the vaccination and addressing the vaccine hesitancy. They were the ones, again, receiving all this information. So they would bring that, share that information in terms of what were the fears, why people didn't want to get vaccinated. And I guess we all know all the fears that were out there, and we were able to develop together interventions that would address those hesitancies. They were providing referrals and, of course, supporting the testing and vaccination events. And with this, I just want to finalize by saying that with all this experience that the Latino Health Initiative have had throughout these 25 plus years working with community health workers, we've now developed a training program that has been accredited by the Maryland Department of Health. And we developed this curriculum based on that experience, but also on the 9 competencies that the Maryland Department of Health requires to certify community health workers. It's a 12-module program. It's delivered in Spanish, 100 hours of instruction plus a 40-hour practicum. It's mostly delivered in person because of the methodologies we use. Manuel referred to popular education methodologies. That's one of the frameworks we use. So we do a lot of in-person work. It's a theoretical, practical, participatory methodology. That's our certification training program now. And with that, I'm finishing, and that's my contact information. And please feel free to contact me. Thank you very much.
Thank you so much, Gianina, for this amazing presentation. We're going to move on to Lorena de Leon from Maryland Physician Care. I'm just going to go ahead and share my screen very quickly. All right. All right, Lorena.
Excellent. Thank you so much, Kelly. Can you hear me?
Yep, we can hear you.
Excellent. All right. I'm going to move us along here because we've got about 14 minutes. So Maryland Physicians Care, for those who don't know, we're the 3rd largest MCO in the state of Maryland. We serve about 245,000 Medicaid members statewide. We're actually owned by 4 health systems that are listed here, which is kind of unique for a health plan. Actually all of our owners are nonprofit, which really means that everything that we make at Maryland Physicians Care really goes back into the community. Next slide. So we, as a health plan, have to look at this as a broader scope. You've heard our colleagues, at a delivery perspective. You've also heard my colleague that talked about a health department perspective. And from a health plan perspective, we're responsible for delivering care across the entire state. So our approach became more of a regional approach. We believe that community health workers and social workers are the linchpin to really getting to understand what the challenges are in the individual communities. And so what we did was we divided Maryland up into 5 regions. And most of you, I believe, are from Maryland, so you know that in Baltimore City, the population is very different than Western Maryland, Eastern Shore, and so forth. And so our goal by doing this is understanding that not all one size fits all, but also to build trust and connections within our community and our local organizations. Next slide. So our whole principle was, how do we move upstream, right? Traditionally, healthcare has been reactive. Something happens like a pandemic, and then we all scramble around and react to it. And so we wanted to create a more proactive environment. And so in order to move into that type of an environment, you need things like data. you need to understand your population. You need to understand their needs, but you also need to get down to an individual level. And so that's what we actually did. Next slide. We use data, and I like to say that data is the new healthcare cryptocurrency. If you've got data, that actually makes you very rich to understand your population and where you need to drive your resources. So many of our health plans out there, as well as health systems, and traditionally in healthcare, we have focused on a risk stratification model, meaning we divide our population based on the risk and complexity. But it's really been around how many times are you using the ER, how much are you costing, or how many chronic diseases. This new lens of looking at things through social risk is something that really the pandemic flashed a huge magnifying glass on. I mean, I think all of us as Latinos know that there was health disparities for years, but with COVID, it really forced everybody else to look at the challenges that our communities and other Black and Brown communities and our Asian communities and LGBTQ plus communities were all facing. So with this data, what it allows us to do is we're able now to look at things beyond. So you may have your type 1 diabetic who was always stable because they had food and they had transportation and they had access to healthcare. Now, all of a sudden, they find themselves in crisis because they lost their transportation, they can't afford their medication, or they may not have a stable home to live in. So we need to start looking at these risk factors further up so that we can address the needs before they go into crisis. Next slide. So that's what we actually did. We designed a social risk score, an MPC, that was focused specifically on Maryland data. So instead of going out, getting a vendor, finding a vendor that could use a big data set nationally and do machine learning, we decided to create our own. So we used Maryland-specific data. We used data that we aggregated and data down to zip code level, street level, and individual level data. And this allows us to basically create a risk score for each one of our members and identify the 3 top needs that each one of the members that we serve has. So we're going in at least with an idea of where their challenges are. It also helps us prioritize who's at highest risk of crisis within our population in a proactive manner, as opposed to waiting for them to hit the ER or something to happen to them before we actually do an outreach. Next slide. So what that allowed us to do was also identify target hotspots. And if you're familiar with the black butterfly in Baltimore, this is our MPC population, and you can see it mirrors the black butterfly, the top picture. Ultimately, what our CHWs did for us is they're able to aggregate that feedback as well as data, and helped us identify where those hotspots are that we really need to focus and go in boots on the ground. As a result, we ended up contracting with a vendor in order to develop a closed loop referral system, not just the typical closed loop where it's like, hey, I screen you, I'm going to give you some resources and you're going to have to go figure it out yourself. We actually have built a network of community-based organization partnerships within these areas that we have high risk member disposition. And we found other strategic partnerships like Instacart or other strategic partnerships like creating hydroponic gardens to address things like food insecurity. So we're not just stopping at giving people resources, we're actually investigating, and our community health workers are linchpins to that. They're going boots on the ground, spending time in the community and finding out what are the true needs and resources. Next slide. So this is actually our deployment model where, now that we have the social risk score that we've been able to create, we are testing the validity and sensitivity and specificity of that risk score now. So far, just on anecdotal and what we've heard out in the community, it's pretty accurate. So I've got to thank my analytic team for being amazingly brilliant and doing things that I can't possibly imagine doing. But we're able to really stratify and go after those members that are needed. We're also deploying a self-screening mechanism because those that are in low risk, we want to keep an eye on. But we also want to give them a tool where they can self-refer into this accountable network that we've created. Next slide. So statistics, we actually launched back in April of last year. So you can see that since April of last year, we had 20,000 outreaches. We screened now, it's actually over 2,100 people. I just got the numbers yesterday. And of those, we had, additionally, we had some that declined being screened, and some people, what we've heard is, they feel like others are in higher need than they are. So they'd rather leave the resources out there, which I think is incredibly humanistic and heartfelt to know that even though somebody's suffering, they're always looking beyond themselves to say somebody might need it more. So you can see the expansion of the program. When we initially started, we had a lot of hits out in Western Maryland, and that was probably our most robust neighborhood. And that's because we have about 85% of the Medicaid market share in Western Maryland. So we really started off our efforts there because we knew we'd hit a lot more members that way. But now, as you can see, by December of 2023, we've expanded throughout a large portion of the state. And we've just hired our team for PG and Montgomery County that are really going to start hitting boots on the ground aggressively. So we expect this to continue to grow as the need continues to grow. Next slide. Yeah. Next slide. Sorry. Perfect. And so this kind of gives you a view of what the top needs are that we've seen across our referrals, right? So we referred 729 clients. Of those that have been screened, about 1,700 had been screened, 729 had been referred out. And you can see the number of services that they were referred out for. So most people have multiple needs. It's not just one thing, right? And we all know that, especially with CHWs and social workers being out in the community. It's like you usually run into a person. It's not just food, it's housing, it's utility, it's a whole host of things. So the primary thing that we are seeing statewide is food. There's not enough food out there. There's not enough food pantry. They're running out of resources. Financial support is the next one. We're seeing a lot of eviction prevention needs. We're seeing a lot of vital documents. We're seeing a lot of utilities being shut off. So these are all very important things that gives us some insight on the programs that we need to develop. And we could not do that without our community health workers. Next slide. So this is some of the member feedback that we've actually gotten through our community health workers. We've had families that have had their SNAP benefits significantly reduced. We're finding out a lot of information about whether or not people have reliable transportation. And in many cases, they have multiple households living under one roof and sharing one vehicle. We're learning a lot about literacy levels. I have one specific example. I was just at a community-based organization last week, and they were sharing with us through the work that they've done with community health workers, is they were sharing with us that one of the biggest challenges that they have right now is people obtaining their driver's license. And part of that is due to the literacy level. And so what they've done is a partnership with the MVA to have them come on site to administer the test, but to answer questions orally and administer the test orally so that they're able to explain things like yield, which some people may not understand what that means. Doesn't mean that they're not capable of driving. It just means there's a barrier to access due to literacy levels. So, again, these are extremely important nuggets of information that we're getting. And most of them are coming through our relationships of our community-based organizations who also employ community health workers as well as ours. We had somebody travel from Odenton to Baltimore just to receive diapers. We're finding that there's this huge diaper and feminine hygiene education need out there. And that people unnecessarily are ending up with pelvic inflammatory diseases, or girls are not able to go to school because they just don't have the supplies for hygiene, or that they can't go to daycare because there's not enough diapers. So definitely, information that we would not have if it wasn't for our CHWs. Next slide. I think that's it. I can't believe I did it all in that short amount of time, Kelly, but I did my best.
Thank you so much, Lorena. I mean, just all the insights from everyone here has just been incredible to learn about what community health workers do and how they provide support in their communities. So I just wanted to, I know we have about 2 minutes left on the clock, but we do have like 2 minutes for any burning questions that any of our folks may have to any of our panelists, to myself. We have about 2 minutes just for any last minute questions. And you're more than welcome to come off mute if you have any questions. Going once, twice. All right, well, I just want to thank you all so much. If you do have any questions, please feel free to email me. You can also visit our website to learn more about some of the programs at Maryland Latinos Unidos. I will go ahead and put my email in the chat. This information will also be sent to all of our registered participants, along with, it will be something that will be made publicly available. It will be put up onto our social media. You will also get more information about our panelists here today. But if you do have any questions, please don't hesitate to contact me. I'm very excited to just have had such a wonderful panel. I want to thank the panel here today, Manuel, Giannina, Lorena, for sharing your insights, your best practices, how you have integrated community health workers within your organizations in a way that's authentic, that you value community health workers and their input, and really sustain them as a workforce within your organizations. So I just, once again, thank you all so much for joining today. We are happy to have had you here in this conversation today. So thank you all so much.